Hi, everybody. We are here again at Not Your Mother's Menopause for another Instagram Live. Tonight we have a really exciting, um, I'm going to introduce as soon as I get everybody in here. Um, there she is. And there's Stacy. We're just going to get our guest,
Hi.
Dr. Julie Lorber, in. So she should be waiting. And let's see if she is coming in. There she is. It worked. It worked. I love when it works so easily because that doesn't always happen.
The only problem is I'm on a phone and not on my iPad because my son is screaming at the iPad, and I just kicked him out of the room because it says I'm not logged in on Google.
Okay. Well, we're live in front of everybody. We're all set. Everybody's, it's there's always like some sort of technical glitch. People who were on before saw us trying to figure out what our problem was.
I know.
Um, but I just want to welcome everybody here tonight. We are back again for another Not Your Mother's Menopause Instagram Live. Don't forget, before I start to talk about who we've got here, don't forget our event is I think it's like 40 days away on January,
January.
January 11th, 2026. There are a few tickets available, so go to our website, notyourmothersmenopausenj.com, to get those tickets and join us here in Maplewood, New Jersey. Tonight, we're really excited to have Dr. Julie Lorber on with us. Julie is a highly regarded board certified colon and rectal surgeon, providing exceptional care for a full range of conditions, including patients needing minimally invasive colon surgery, colonoscopy and polyp removal, treatment of fecal incontinence, treatment of ulcerative colitis and hemorrhoids, and pelvic health. Dr. Lorber has been a colon and rectal specialist in private practice since 2007, and she's a fellowship trained and board certified in colon, rectal, and general surgery. Dr. Lorber earned her Bachelor of Arts, graduating cum laude from Cornell University. She continued her education in medicine to earn her medical doctorate in her home state from the Medical College of Ohio. Following this, she completed her internship, residency, and was a chief resident at Boston University. She continued her training, completing her fellowship at Orlando Regional Medical Center MD Anderson Cancer Center. She practices in Summit, New Jersey, with privileges at RWJ Barnabas Medical Center and Overlook Medical Center. And she is a returning scholarship sponsor of Not Your Mother's Menopause. And with her support, we are able to offer lower price tickets to our event to those who need them. So it's a very important part of what we do. And we're just so happy to be here. So thank you for coming.
Hello.
So I just
That
want to
was a
start.
lot.
I know it's a lot. I had to call from your website, as we know. So I had to call from but there's just so much to say because you have so much experience. And I'm always, every time we have a doctor on and I'm reading the doctor's bios, Stacey, you probably come up with this too, is that I'm always amazed at like how long the education part is. And it's in like, and for 15 years they were a student. And I'm just like amazed. Anyway,
So true.
so
It
long.
is exactly 15 years that I was a student.
It's so long. It's so long.
Long time.
Can you
Yes.
tell us, Dr. Lorber, what a colorectal surgeon is?
So, a colon and rectal surgeon is someone who specializes in, I always say, butts and guts. I take care of colon problems, a wide variety of colon problems, both from a medical and a surgical standpoint, and also anorectal pelvic floor type problems from the same perspective. So, although I came through surgery from my background, through residency, the specialization gives me information in both medical and surgical experience in colon and rectal. Whereas a gastroenterologist specializes first in medicine and then continues on to do their specialization. So they come from a different perspective and background in GI type diseases.
So do you have to go through that gastroenterologist training and then Like, is it all or colorectal surgeons are also
Cor-
gastroenterologically trained, but not the other way around, right?
We're all trained as surgeons, and then our fellowship includes the GI aspect and the specialization, but we don't come from a medical background. The gastroenterologists learn their procedural work during their fellowship, and that's where most of it comes from, rather than learning the, sort of integrated
Okay.
specialty.
Yeah. I always find it very interesting too. Like, I remember when I first met you, I asked what made you want to become a butts and guts doctor, because it really is quite a specialty. So
So the answer is really that I do a lot of preventative care by doing colonoscopy. I treat diseases that are across the life spectrum in both men and women. So cancers and inflammatory bowel disease, I stay with those patients, sort of throughout their lifespan. And then the anorectal stuff, the hemorrhoids, the fissures, things like that, I deal with on an acute basis, but I usually can fix people very quickly.
yes, good. Um, I guess we're going to get right into it because we are here to talk about menopause and the work that you do. So menopause in the gut is what we've titled this talk, although we know it goes further than just the gut, because we are going to talk about pelvic floor as well, which is something that both you, Stacy, and Dr. Lorber have a lot to say about. So can we talk about some of the changes and some of the symptoms that you see um, in your office with your patients in this population, in this sort of perimenopause, menopausal transition?
Yeah. So about 80% of patients who are going through their perimenopause or menopausal transition have complaints of GI symptoms.
80%.
80%, yeah, 80 to 85%. So it's really common. And there's a variety of symptoms. The majority of patients that have symptoms will complain of bloating and constipation, but there can be, sort of variability in GI symptoms as well as food tolerances. There can be some
Mm,
changes in food tolerance. So it's very common to complain of different GI symptoms, and also there can be difficulty with going to the bathroom. That's not truly constipation, which Stacy can speak to as well. But it those are the major symptoms that people complain of. Then there are, normal age related symptoms. And I say that because it affects both men and women. Things like increasing numbers of patients complain of hemorrhoids and bleeding. And we start testing for polyps and, cancers at this point in life too. So,
yeah. And there's a lot of talk, like when we talk about the menopausal population, there's so much talk about the changes. A lot of the talk right now is about the changes to what we call the gut microbiome.
yes.
Um, so I'm wondering if you could talk a little bit about that, like maybe define for some people who might not know what that is and how that is affected by the change, fluctuation and decreasing levels of estrogen.
Sure. So there, there's both effects of changing levels of estrogen and effects on changing levels of estrogen. So the gut microbiome is a cluster of bacteria that live in the GI tract and assist with metabolism and with digestion. And we all have bacteria throughout our system, but especially within the gut, it is a very important player in health. And we start with a gut biome when we're born. And the biggest change is actually for nursing babies between the time that they are nursing and the time they change to regular food. And so both boys and girls have similar flora at that point, and during that transition there's a divergence during puberty in that microbiome and the different levels of different bacteria. And so there's a divergence between men and women at the time of puberty. Our peak of microbiome diversity is around the age of 40. And then as women go through menopause, they start transitioning back to a microbiome that's more similar to men again. So we have this period where the microbiome is differentiated between men and women. Um, so,
And that's during the reproductive years.
and that's during the reproductive use. It's not clear as to why that is. I mean, the research is just beginning into what the microbiome, what effects it has on health, and what those changes really mean during that period, and the differences, and the fact that they become more normalized. Um, there, but we do know that those changes exist. There are very few studies that actually have good science behind them as far as how we can change that microbiome. There are certain medications that affect that microbiome. Interestingly, we know that in younger people, the microbiome, specifically Klebsiella, is really affected by some of the SSRIs. And the reason I mention that in particular is because even during the reproductive years for women, and men for that matter, who are on these types of drugs, these have been studied the best. And Klebsiella happens to play a role in estrogen metabolism. So when Klebsiella goes up, estrogen levels go down, even during those reproductive years.
Huh. So
Um,
and so what you're saying is that, so Klebsiella is a flora.
Correct.
Okay. And that lives in your gut and it has a specific role in your health to manage levels of estrogen.
It's one of the bacteria that does. What we know is that estrogen is produced by, the reproductive organs, and it's processed through the liver. And when it's processed through the liver, it no longer is in its active state. And then it's actually, it is basically released through bile. So the liver produces bile, it's stored in the gallbladder, and then gets to the gut, to the small intestine, and then to the large intestine. And what we know is that there are bacteria in the GI tract that reactivate much of that estrogen. So what is conjugated by the liver is deconjugated again by these bacteria to allow for higher levels of estrogen. So if you have imbalance in certain bacteria, you're going to have less estrogen because it's not going to re-enter the system and be recycled. And what we know is probably somewhere in the neighborhood of about 50% of estrogen is excreted in feces, and the estrogen that's resorbed through these bacteria accounts for about you get 35% back.
This is
So,
like
yeah.
mind-blowing. I know.
Yeah.
I don't even know. Okay, so could they, I'm just going to say something really weird. Like, could you have a fecal test to tell instead of a blood test to have a better sense of what your estrogen levels are?
Um, I don't think that really tells you what you're losing, not so
What you're
much what
losing.
your
Okay.
estrogen levels are.
Yeah.
And you can do a comparison between what you're losing and what you have, I guess, but
Yeah.
I don't think that it would necessarily be that helpful.
So if we have this during our reproductive years, so there are things that are fluctuating because there's outside influences that change the microbiome, right? So we're having effects on estrogen production. So then once we pass the reproductive years and we're coming out of those, like what happens then? Because so the estrogen levels are going down that are just created by our body as women, but the generation from them or the reigniting from it, I guess is what you're saying, from this specific flora in the gut isn't going to happen either, because there's also something, because there's less of it, right? So
Yeah, so there's probably some changes in the gut that's causing less to be allowed to be recycled, and we're producing less. So the gut microbiome changes exacerbates that. So we both have less and we have less recycling of that. But it's unclear as to how we can adjust this
Right. It's like, what do we
microbiome.
do about it? Right.
yeah,
Yeah,
Like,
so this is a little less clear. I mean, certainly um, some of the things that we can do are, fiber is and other probiotic, or excuse me, prebiotic
chaotic.
foods. So we talk about prebiotics and probiotics.
yeah,
And probiotics really we use to describe things that you can take, like supplements and that are not brought in by foods. We reserve prebiotics for foods that then get broken down to provide that bacteria, whereas probiotics are like the supplements that you can take. And one of the things we know is that prebiotics, generally taken in by food, do tend to help improve gut bacteria and gut flora. But the probiotics, it's unclear, what probiotics are getting broken down by the gut and that you're taking in, and how much of an effect they have on that microbiome. So certainly there are a lot of supplements that are utilized, and we try to adjust gut bacteria with those probiotics, but you're much better off with hydration and fiber and other types of foods that have,
Right.
fermented foods, and yogurts with cultures and things like that. You're much better off utilizing those than taking a supplement, actually.
Right. Right. So
which seems to be
interesting.
what happens, right, Stacey? I mean, we see this all the time, and we see this with everybody that we talk to in this, like so many of the providers and experts that we talk to in this field is the importance of actually getting the nutrients and what our
Yep.
body need through
Yep.
actual real food, and it just comes up. It's amazing to me how this comes up over and over and over again.
You can't
You know?
sort of make up for bad food choices with supplements.
Yeah.
Um,
Right. And I
and
think,
that's true pretty much of all vitamins right
yeah.
now. I mean, we know that a lot of vitamins are excreted in the urine if they're taken in too high doses, or if you're taking them orally, and in the feces. You're just not
Right.
getting the same kind of benefit as you do with healthy food choices.
Right. And I think too, I think there's, the colon is fascinating, right? It's just, it's fascinating. It's a very slow learner. It doesn't like change. It doesn't like a drastic change. And I think there's a lot in my practice too, where patients will come in, whether they're in menopause or not, when you find out the history that goes behind it, right? Like, I say everything starts at potty training, right? It
Yeah.
really does. Like, it goes back to like how you were taught about bowel movements and all of that, eating, how we process it, like all of it goes back to like how we potty train. And even though we're going through menopause and going through changes, like there are some people that come out of the womb screaming, and there are some people that have a more calm effect. And that also plays a role in how we digest and rest and all of that. And all of these little things like fiber and water and changes, like for some people that have never done it and they've eaten not in a great way, and then they hit menopause and they're like, now I'm bloated and constipated. And yeah, well, you've been doing this for a long time, right? So it's these little changes that you have to do, and it's just fascinating to me.
Well, and I would also say that if you go from 0 to 100 with fiber, so
Forget
the goal is
forget it.
between 25 and 30 grams of fiber, you're going to have a lot of side effects. Like your system
Absolutely.
just isn't going to tolerate it. You're going to have a lot of gas and bloating,
Yep.
and you have to make very slow incremental changes to get to the point where you want to be with some of these foods, because you can't just add it in and assume that your body's gonna be okay with it.
Yeah, they did a research study on effective of psyllium husk, right? Like just psyllium husk. And the outcome was really good. But the problem was when you read the study, they gave people 2 tablespoons of psyllium husk to start. And it's like,
No,
they
you that's
weren't there.
ridiculous.
It's crazy. It's too much. Like you have to start really slow. Like the colon's a very slow learner. Doesn't like change, doesn't like to travel. It's like
Like
not,
to travel.
it's not like
It
travel.
doesn't.
It
Is that
doesn't.
is that vacation constipation? Is it the colon?
Sure, sure. And the airplane dehydration, yeah,
Yeah.
it's
Yeah.
real.
It also doesn't like to be on fight and flight, like fight or flight. It doesn't, it runs by parasympathetics. Like all of
Yes.
our patients that come in, no offense, lawyers. I've got lawyers. I don't like yoga. It's too slow. It's because their body doesn't want to calm down. Like you've got to bring your body down. Your parasympathetics are what make us poop, right? It's what makes
So
us
true.
poop.
Yeah.
My God. Yeah. And it becomes one of the things, like, just to get a little bit personal, but one of the things that, and it's interesting to me that number, Julie, that you mentioned 80 to 85% of menopausal patients complain of gut issues. That for me was and remains to be not that, I don't know, one of the top of the heap of things that I'm dealing with going through this. And I absolutely notice the immediate changes that happened when I started HRT. Like it was literally in 24 hours because I had really been suffering with a lot of discomfort. Both of you guys know this because you know me personally. So both of you know this. And, you know, I would say that just introducing estrogen at a regular and intervals and level for me through HRT made such a huge change that I was like 85 to 90% better. I still have whatever I have, but it's, I was shocked because I had been trying to figure out what was wrong with me. I did all the diet things and all the therapies and all the this and all of that. And nothing really helped for any long period of time until I was able to give myself some estrogen back, which was amazing to me, you know.
Yeah.
Yeah. One of the things too that comes up with the gut microbiome, and you and I have talked about this, is the notion of the connection between the gut and the brain, or the gut brain axis.
Yeah.
What can you tell us about this? Because especially when we talk about menopause and we talk about all the cognitive changes that can happen as well, with the declining levels of estrogen, age, all this kind of stuff. Like, how much do we know how much that is connected to the microbiome or just to the estrogen or to both? We don't know very much.
I don't think that there's been good literature to suggest exactly, you know, we talk about the gut microbiome, but there's really not any literature to sort of differentiate between estrogen versus the gut biome versus, sort of what absorption of toxins is like and leaky gut and all those things. It's very new science, and I couldn't find anything in literature to explain, you know, why, gut brain
Access.
health. Yeah.
Yeah. Because you hear it a lot, and I wondered like how much of this has been really studied on a clinical level, and it doesn't sound
Not
like
so much.
much.
Not so much.
Yeah. Yeah, because it's scary because, you start think people get nervous, I'm going to lose if I'm not eating enough sauerkraut, I'm going to go
Yeah,
crazy. And I don't eat enough sauerkraut. So,
I'm not
Everything
a
in
fan.
balance.
I,
Everything in balance. That's the key. You've got to be on kind of this, like any extremes are just going to wreak havoc. Like you have to find that kind of like neutral ground. I think it goes with everything too. And everyone's different. Like that's the other thing, right? Like
yeah.
we see that at these events, like there are some people that can tolerate X amount of estrogen or progesterone or something like that. Some people it changes. But again, they have this long history, right? We're in our, like, what's the average age of menopause is like 55, right? Like
51, I
92.
think, right now.
51,
Right. So
yeah.
I think by
51.
like, what is it? Like 95% of us will be through menopause by 55. But everyone comes with a totally different history,
Yeah.
right? Like, it's very interesting. And there is a mind body connection to the colon, meaning the brain does do stuff. Like, stress does play a role. And I'm sure the hormonal fluctuations play a role. And, it's like how bad, there are some people that go through menopause. They didn't even like realize they went through menopause. They're like, I don't know what everyone's talking about. Why do I have to go to an event? I feel fine. It's just, I don't know.
I
But
know.
But the other thing you have to keep in mind too is the absorption affects glucose levels and insulin levels, and
yeah,
Yeah.
so you have thyroid levels tend to change. So there are all these hormones, not just the
estrogen.
estrogen and progesterone, that are playing a role in this gut microbiome. So it can't be and the gut brain axis. It's you have to. I mean, there's so many sort of intervening factors that play a role in this in these changes.
And
So
what about, like, I don't, can you talk a little bit about, like, you brought up insulin, glucose. It's something that comes up because we've learned that through menopause your insulin resistance can wane, and enter in GLP-1s, which are
yeah,
really starting to become a huge part of the conversation for a number of reasons, not just for that, for blood sugar, but also because women gain a lot of weight during menopause. A lot of women gain weight in menopause that doesn't make them feel comfortable, and here's
yeah.
something that can help them. So I wanted to make sure we brought that up.
Yeah, so if you think about it, your reproductive hormones stop producing estrogen as we get older, and a lot of the estrogen production that remains is through the androgen pathway in adipose tissue, and
Yep.
that's how we're getting some of the estrogen. And so, because
So
of
our body
that,
adds it on because it
yeah,
needs. So our body says, "Wait, I'm not
exactly.
getting it where it needs." So the adipose tissue, for people who don't know what that is the fat, right? It's in the
Yeah.
fat around the organs mostly, right?
Yeah,
Mm-hmm.
but it
Yeah.
can also, yes, and women tend to put less fat around the organs than in the sub-Q. That,
Okay.
but yes, it's any sort of fat.
Okay.
It can occur around the organs too. But yeah, that increase in fat comes because, in some ways, because that's where estrogen production comes from. Once the ovaries are no longer the
It flows.
major producing factor. Yeah, exactly. Once that shop's closed.
Good job.
Um, but so I think that's why there is an increase in adiposity during the peri and postmenopausal time, and so people are now going to GLPs, which can affect insulin. As far as you mentioned, insulin resistance. That means that the insulin is not doing its job, which is to bind on the cellular level to allow for glucose metabolism. So you get higher levels of glucose in the system. And so the GLP-1s help to mitigate that effect. We don't know exactly how GLP-1s affect weight loss. I mean, we know that they do. And there are some other, drugs that are in that category now that people are taking. They definitely have a huge effect on the gut, and that's part of the way they work. So the way the GLP-1s work is they slow down stomach emptying. They cause gastroparesis, which can cause reflux and belching and abdominal pain. which I see a lot in patients.
Mm.
It also slows down the intestines and the colon, so you get slower
Constipation.
function, and that can lead to bloating and discomfort as well, and severe constipation.
Yeah. Is
So
that something
all
that
the
you see a lot? And so poor
so,
women, they're like they've gained 15 pounds overnight. They're feeling bloated and horrible. They're no estrogen. They're not hot flashes. So they do one thing, they go on estrogen, they go on a GL, or they do two things. They go on a GLP-1, and then all of a sudden nothing's relieved. Like, so they're still bloated, but, and now they're not hungry. So,
right, exactly. I mean, hydration is also a problem too with both of them, because if you're not hungry, you're generally not hydrating well, and hydration is so important as well as a part of this, for both constipation and for relief of some of these symptoms. But
yeah.
I don't see them as side effects of these drugs. I mean, they're expected effects of these drugs.
Oh, really? Okay. It's not a you might get this. It is you probably will get this.
Sure, because that's how these drugs work. I mean, that's the whole, way, that's the whole way they function, to depress appetite, is by doing all these things to the gut that that has the side effects, of the bloating and the nausea and the reflux. All those things are expected, because that's what these drugs do to the system. They slow it down on purpose to make you feel full.
Yeah.
That's sort of the gig. So when people come in and have these complaints, that is, some of my first questioning. Well, did it start when you started the medication?
Yeah.
Um, sometimes it does. Sometimes, yeah, it got worse. You know
Yeah.
that. But interestingly, I also see anorectal problems, hemorrhoids, fissures, things like that, because of the constipation. Then you start having, sort of effects of the constipation, which causes pain and bleeding and sort of anorectal type symptoms that also then need to be treated.
And I know that a lot of people, especially that I talk to in my work, when we talk about GLP-1s, a lot of people, some people are curious about it. They want to, they're not sure. And people talk about, we don't know what the long term, they feel like there's not a lot of understanding about what the long term effects are. And um, when you say, when you talk about these kind of gastrointestinal side effects that are happening, like what's actually happening, and you think about like what is the long, like obviously, if you live with a slowed down digestive system for a long period of time, other than those more immediate effects of bloating, constipation, discomfort, living like that in the long term, like what can that do to your system, like that we haven't had the chance to figure out yet because we haven't had this like mass usage for so long.
Yeah, and I don't think there is an answer. I mean, I suspect that it also has an effect on the gut microbiome, because
Yeah.
you're slowing things down. So, the colon in particular utilizes food as it passes through the system. It doesn't just use food that we take in, by mouth per se, but also um, it uses some of the as stool is produced, some of the sugars that are in the stool are used for gut metabolism too. So I wonder what effect it has on the microbiome, and I don't think there are good answers. I
Yeah.
mean, I think that is yet to be determined,
Yeah.
amongst other things that we don't know about these drugs
Yeah. Yeah.
and
There's
the
a lot of
long-term use. Yeah.
a lot of unknowns, a lot of unknowns.
Yeah.
And there's a lot of positives that seem to be coming out of it as well, though. Like on the other side of it, they do, there's a lot of positive news that comes out of it. So I think it's very confusing for a lot of people. We're
Yep.
going to talk a lot of, I think we're going to wind up talking a lot about it at our event on the 11th. Yeah.
Yeah.
Yeah. What about switching just a little bit to the pelvic floor? Because I know that that is something that is, surprises me when you say like, oh, I'm a pelvic floor specialist. And I'm like, oh, Right. Okay. Of course you would be. And also having Stacey here, like talking about changes to the pelvic floor during menopause, how that would affect your gut function, how that enters into what you do practice.
Sure. Well, I think that the decreases in estrogen and also just the constipation that people often complain about with you know,
Menopause.
aging. I mean,
Yeah.
I think some of it is menopause, some of it is aging. You get weakness in the pelvic floor. Things tend to sag. I think with less estrogen, the bladder changes its position. So if we think about the pelvis, it has the bladder up front, the gynecologic organs in the middle, and the rectum at the back. And
Right.
pooping is a very, very complex process. It's a very complex, coordinated process, as I'm sure Stacy can speak to as well. And so everything is about relaxation
Absolutely.
of the rectum, so it straightens and the anus opens, and we can poop. And the problem is a lot of times with constipation and straining, the rectum gets stretched out. The pressures are not down and out. They're sort of spread out in the rectum, so you get changes in the shape of the rectum. It can pancake on itself, and all these things then cause in and of themselves, they can cause bloating and worsening issues with evacuation. And so a lot of times we can do assessments of muscles in the pelvic floor, the nerves in the pelvic floor. Our neurologic system slows down a bit. The muscles, we don't have as much muscle bulk. So all these things affect how we feel as far as bloating and gas, and they also affect how our function is.
Yeah, I think it's all too, like, I think you probably see a different scope of what I see because you're the colorectal specialist that's seeing the fecal incontinence and that laxity per se. I see the imbalance. I see the visceral abdominal wall weakness, which actually leads to pelvic floor tightness. And
Yeah.
pelvic floor tightness will cause constipation, even just from that rare reflex, right? So, that pelvic floor, when it's tight, it's going to shut down the ability for you to feel like you're going to have a bowel movement. Like it's going to prevent it because it's just contracting so much. And it's interesting from a constipation perspective when we look at the people that have that laxity, I always say, I'll like send a message like, can you tell this patient to use estrogen around the anal area? Because they're so weak and it actually plumps up that muscle from that perspective.
Does it
But
work?
yeah,
Do people do that? Like, is that prescribed estrogen, like
I
vaginal
bet.
estrogen in the around the anus instead? I mean, why not, right?
Why not?
Yeah, it can
Right?
be used. Absolutely. And I just want to point out, Stacey, I think I separate constipation and evacuation as two separate processes.
Totally.
So we have this, constipation can lead to difficulty with evacuation, but evacuation problems can give you the same symptoms as
Absolutely.
constipation. And it does,
Yeah.
and when I say that, I mean constipation really is motility through the colon to the
Right.
rectum, which is
Right.
sort of this holding cell right before you poop.
Right.
And pelvic floor is what's keeping things in the rectum. So for me, that evacuation is affected by tightness. And so a lot of what I see is, the fecal incontinence can be related not just to low estrogen, but also to, obstetric injury and changes and things like that. But the tightness, I see a lot of pelvic tightness.
Hey,
And that's
we're just seeing so much.
even if the tissue is lax. So even if the
Right.
rectum is stretched out, even if people have rectocele, which is is where the rectum bulges towards the vagina. They can feel a bulging, almost like a feeling like the rectum is falling out of the vagina. Gynecologists use rectal prolapse. We use the term rectocele. But even when you have laxity in the connective tissue in that area, which happens to the abdominal wall too, without estrogen, the tightness in the pelvic floor and the lack of coordination, that lack of relaxation is what makes it so difficult to evacuate.
And it's so interesting to me because it isn't just about pelvic floor muscle strengthening. Like, I feel like it's just a whole balance of stuff. I mean, Allison, you and I talk about this all the time. Like, the amount of patients that are just weak in so many different areas, right? And then become the weekend warriors, or they join like a mass program where they're going to get really strong. And what do? They bear down, right? So
Yeah.
like then they create more dysfunction. And they look at you and they go, I have no idea what I'm supposed to do. Like, I don't understand how I'm supposed to defecate, right? And defecation should be a great defecation. We all know we eat something, we get an urge, the urge is good, we've eaten really clean, really well, our stool consistency on that Bristol stool scale is a perfect 6, and boom, something comes out and you're just like, okay, like that's how I'm supposed to defecate. Like, I'm
Like the
good.
best.
And
Yeah.
that's actually how it should be, right? Like, it should be easy, but life, right? Life happens. And it's like you didn't eat well. Maybe you're taking medications that are slowing stuff down for other things. Like, you are in perimenopause and things are changing. I don't know. I mean, like, it's crazy.
Yeah. Yeah.
Totally
Yeah.
crazy.
It's amazing how much, the more we learn about everything that's affected, like literally everything is affected by this stage of our life, by these declining and fluctuating levels of estrogen, and here we're sitting here tonight talking about gut microbiome. And what about, I do want to ask you though, the rising numbers of colon cancer in young people, like,
Oh,
are
that's a
you
good one.
seeing, because this is like a big thing, and I know that you see this a lot, and I want to get it in before we have to say goodbye, but talking about that, um what you're seeing, what
Sure.
your thoughts are, what's
So
happening.
we do know that there are higher levels of colon cancer. I should say increasing levels of colon cancer in people 35 to 50. That's why the age for screening colonoscopy dropped to 45.
Mm.
Screening tests are to catch the majority of people who are going to present with disease, but a lot of what screening age levels come from, and it has to do with economics too when it comes down to it. What is
Mm,
cost effective for the insurance company, for the government, because they set a lot of those guidelines initially. But that age dropped to 45 a few years ago,
yeah.
because we are seeing increasing numbers, and it's in younger people. We don't exactly know why. I don't think we can point to one thing. There have been lots of studies about what specifically leads to colon cancer, what sort of lifestyle habits, and I mean, the genetics we definitely have a lot of information on now. About 15% of patients have Lynch syndrome, which is a specific genetic predisposition to having colon cancer. There are
Hmm.
familial risks. There are some other genetic changes that definitely put you at risk of having colon cancer younger, and we know about those more. So those patients we can pick up and follow, because if they've had a family member with colon cancer, they can then be screened and tested for that gene and start their screening earlier. But the environmental factors, the dietary factors,
Yeah.
there's been a lot of research on that, and there's not one specific thing that has come up statistically significant that really affects. So, whether it's, they've tested, fats, animal products, um, other types of diet modification. There's been no study to absolutely suggest that those changes are going to affect your risk. Probably they're just in combination. Um, and and that's, I mean, obviously smoking and marijuana use and things like that do show
Do
some
that.
statistically significant changes. So those lifestyle modifications, yes, but diet ones, I
Unknown.
can't really speak to it. I think it's still unknown. I remember even when I was in training, almost over 20 years ago, they were also trying things like cholesterol lowering medications to see if they decreased your risk of colon cancer because there was less fat exposure in the colon. And originally they thought the literature was good. Not so sure anymore. There's probably an inflammatory component because we
Mhm.
do know that anti-inflammatories and aspirin do decrease your risk
Oh,
of
that's
colon
interesting.
cancer and recurrent colon polyps. So that is something that is a modifiable factor, taking like a baby aspirin a day. Now, one of the
That's very
interesting
interesting because
things
when you
about
talk about menopause and you talk about the decreased inflammatory response that we have, are we going to see, like, are we seeing, is it, I mean, can we even see or tell? Can we take out, are menopausal women getting more colon cancer, or is it hard to know because it's connected also with, is it just age or is it menopause?
correct.
Yeah.
I don't think it's easy to parse out, and we still see, colon cancer has a slight, higher number in men versus women. So,
Okay.
uh,
But
yeah,
it's to get your colonoscopy at 45, and that's
yeah,
like the thing, right? Like everybody
absolutely,
should be screened, and that's the key.
yes,
Yeah.
absolutely.
Yeah, and yeah, I mean we just had a comment saying that the decrease in the inflammation makes sense. Perhaps, is there a world in which using HRT to sort of reset your inflammatory response could help decrease the risk of colon cancer towards as you age?
I think certainly time will tell.
Yeah,
I mean, I don't think that there have been, prospective studies regarding that, but that certainly, we know inflammation plays a role, so that would make sense if the HRT is affecting the immune
yeah,
system. So,
yeah.
but again, yet to be determined. There's
There's
not
so
a
many
lot of
unknowns.
good prospective research on these things.
Well, in your spare time, you can start doing some research.
I'll get right on that.
Julie, I think
Get
there's
right
so much.
on that.
This has been so great and like
Love
super
it.
interesting. And I always love talking with you about this stuff because it just fascinates me. And learning about, what is known and what is unknown about all of these things and connected to menopause is super interesting. So thank you so much for
You're
joining
welcome.
us. It was really
Thank you
fun.
for having me.
I can't wait to see you again. And thank you for sponsoring Not Your Mother's Menopause and being such a great supporter of what we're doing and of women's health in general.
Thank you.
Bye, everybody.
Bye-bye.
Bye.
Bye.